We just had to do it, and we had to do it out of need because our patients were needing treatment at the time that we didn't have that many resources available as we are now. We didn't understand much on how to manage these patients and all these new advances and using the bobby to cut electrically stuff. So again, I'm going to go back to how we started. This Transseptal Antegrade TAVR was described initially by Cribier, and that's how the first human cases of TAVR were done, but then people steered away from them because of this laceration to the anterior mitral leaflet and severe MR after TAVR. We developed multiple access options, especially 5 years ago. We had a group of patients that would not qualify for the trials, that would not have any approach feasible, and the resources we had were not good for treating the patient. So this is one patient. This is how we all resumed doing TAVR. So this is somebody that was referred to us from Jacksonville. We were, I think, one of the first sites doing TAVRs in Florida. Were there with Bill O'Neill. And I had an old video from Cribier on how he did the first TAVR, so he had all the steps into that video, and I had Bill that had done the first transseptal antegrade TAVRs in the country with some of the results that I showed with laceration of the mitral leaflet. So the surgeon said no to transapical, no to transaortic, and there was no possibilities of doing transfemoral. Because the devices that at that time needed at least 7 millimeters of diameter. So the STS score was high. The patient was not a surgical candidate. When she presented initially, I did a BAV, took her off the vent, and we sent her back to Jacksonville. Then 3 months later, I get a call again from Jacksonville saying that the patient is back in the hospital. So we had to come up with an idea, and then we put ourselves together, looked at the video, developed a plan, created a PowerPoint. We posted all those pictures in the cath lab so we could follow a plan. And we were three people plus a fellow doing this case, 2 at the right side of the patient and 1 at the left side of the patient. So vascular access consisted of arterial and venous access in each one of in each side, right and left. We use the ultrasound for access always. We first did a retrograde BAV just to make room for the valve, and then we exchanged the right venous sheath for that Retroflex sheath that was used in the first generation cases in the beginning. As you can see, this looks more like a mitral clip than anything like the sheath of a mitral clip. So then we did the transseptal. Bill was doing here the transseptal without TE guidance, as you can see. But the transseptal had to be in the posterior, more in the posterior aspect of the fossa valley, so we had room to make a loop. We had 2 pigtails, one in the aortic valve, one in the ventricle. We have a pacemaker, and we have the patient here with a swan. I think we probably put from the arm. So the first part was to establish the loop, the ventricular loop. So we went with one of those Medtronic blue catheters that have a balloon there. Those are nice 7 French catheters that we would float through with a molding sheath through the LV into the outflow tract and then in the aorta, and then advance a wire into the descending aorta. The key here was to use a nitinol wire, the Nitrex wire, because this wire is on kink, and that would, if you keep the loop loose, then you would avoid injuring the mitral valve and mitral regurgitation. So that was the key, use a 400 centimeter EV3 Nitrex intermediate wire. Then once we got into the descending aorta, we used one of those 3-lobe snares just to grab the Nitrex wire and externalize it from the other side. Then from the other side, using that same wire, we would advance a multi-purpose guiding catheter just to stabilize the position of the valve, and I'll show you now. But before that, we had to, before going with the valve, we had to do a septostomy, open, make some room there for for the valve to pass, and initially we used a 10 or 12 millimeter balloon, but then we found out that using that XXL Boston Scientific 16x40 esophageal balloon gave us more room, and then the valve would hang up less in the transseptal. So the next thing was preparation, and here there was lots of improvisation and creativity. We didn't have that many resources, that many balloons. The true balloon was not available at that time. We only had the Z-Med. So we used the crimper from another valve, and we used the measurements. We used volumetric expansion, and we created our delivery system by crimping the valve into a Z-Med balloon the similar way that Cribier did it in the beginning. So this is the critical part. When we are pushing the valve and somebody is holding a little bit of tension from the other side. And the best part is when the loop is created and then everything reconstitutes, because there's torsion to the heart at that point, and the blood pressure just tanks down until you recreate that loop, and then you get your transcatheter valve there in your ascending path. So two people have to be in control, one in each side of the patient. And here, as you can see here, there's a catheter that will top the transcatheter heart valve balloon and delivery system, and prevent it from just a watermelon sailing forward into the aorta. So this is a critical part here, measuring that we are at the right place with the valve, trying to be as coaxial as you can. You have control from both sides. And this is the valve deployment under rapid pacing. So the idea is to just keep tight control of the retrograde catheter, so the valve doesn't advance into the ascending aorta. So, and this is obviously, I'm going to show one of the best results we had. So this is so then we pull the wire back. And then we leave a pigtail. We protect the mitral valve with a pigtail, so we're pulling the nitrix wire from the loop. And this is the final result with one of the early SAPIEN valves. So the patient did well, and then 2 hours later, we were very satisfied that the venous, and this is what we see with venous procedures, that these are relatively benign. We didn't put a large hole in this patient. She was having some platane and some Cuban stuff there on the bed. So then we continued to do these cases. We did these cases in patients that were really difficult at that time, and we did 9 cases in a row. In a couple of, I think in one case we could not advance past the mitral valve, and we had to retrieve the valve because we were just not able to do it. So it talks to how the technique could be improved if needed. And I just ran into Bill, and he's developing now a Transseptal Antegrade technique and going through the IJ as opposed to going from below. So in conclusion, for this technique, I think remains an option. It's available for whoever wants to do it. It's very involved, needs lots of manipulation and control, antegrade and retrograde. Should be done by operators who know what they're doing, and using the nitinol wire appeared to be important, just maintain a wide ventricular loop and avoid severe MR or damage in the mitral valve. Just putting this in perspective, I think that TAVR equipment has now evolved. At the time we did this, only 50% of cases could be done transfemorally. Now approximately 90% of patients can be done transfemorally. So all these alternatives become very niche procedures. We're doing very few alternative access cases. And now transaxillary, that was not available at that time for the Edwards valve, that was the only one approved, now is another option, and transcaval is also another option that may obviate the possibility, the ventricular loop and damaging the mitral valve. So this is what I had. Thank you so much.
That was great. use ultrasound to get venous access,
Yes,
but you didn't use to get transseptal access.
correct.
So you must not care too much about where you punctured the septum, huh? for this?
Yes, and these were cases done in the beginning, and I think that with all the things that we know about transseptal access and where in the fossa you want to go, I think it's, if you do mitral clips, if you do left atrial appendage closure, and whatever you want to do, I think I would not recommend going blind and puncturing transseptal blind. This is a skill that early operators had by just going by feel, and I don't think that you need to go by feel anymore, to be precise.
What should be the target for this approach in 2018? Like no transcaval option patients?
No transcaval, no transaxillary cases. Occluded aorta.
It's 1 out of 10,000 patients.
Hmm? And then you don't even need to go femoral, because all you need, the retrograde access, is to just maintain the valve, prevent the valve from moving forward. But I think it's good to know. I think it's good to know that it's available. All these steps have been described recently in Paul's atlas of cases. And we also described the technique a few years ago in that CCI paper from 2013.
Was it performed with new TAVR systems?
Hmm?
Was it performed with SAPIEN 3?
Was no SAPIEN 3 at the time. Was performed with the original SAPIEN and a Z-Med balloon. And the sheath was the Retroflex, original sheath that was like 24. I think this was a 23 valve. One of the things we learned is that the Crimp valve would not go very well on the 24 sheath. We had to use a 26 French sheath to do it. And I think the transapical was 28 French at the time. So we used a 26 French to deliver the 23 millimeter valve.
I think at the end of the day, this is obviously there's been many developments, but the technical aspects of this case are probably the most important. How do you challenge this problem? How do you do this problem? How did you do it? And there's a lot to learn from that. So I think thank you very much, Dr. Cohen, for sharing that.
Thank you.
Great outcomes. I think one of the small pleasures in life is seeing people that you've mentored or grown to know take on to new heights and surpass things that you've done. And with that in place, I'd like to invite Rahul Sharma from the Carillion Clinic to come up and talk about a case of challenging LAA closure.